on what we know has saved countless lives and can save more. Vaccination rollout continues to progress in most countries, including in lower and middle income countries. Yet, millions of people remain unvaccinated in many parts of our region. We must find better ways to reach them. While doing so, we need to prioritize giving a second booster shot to the most vulnerable, including older adults, immunocompromised individuals, and those with underlying medical conditions. We are also urging countries to administer influenza vaccine along with COVID-19 vaccine whenever feasible. But individuals should continue to understand the steps to protect themselves too, like wearing masks indoors in crowded places, on public transportation, ventilating spaces well, and regular hand washing. These are not new messages, but remain critical to personal safety. As requirements have been lifted, the choice to use these simple but effective measures is with each of us. The second action I want to emphasize today is towards elimination in the context of the monkeypox outbreak, with the European region recording more than 22,000 confirmed cases across 43 countries and areas, representing more than a third of the global tally. There are encouraging early signs as evidenced in France, Germany, Portugal, Spain, the United Kingdom and other countries that the outbreak may be slowing. To move towards elimination in our region, we need to urgently step up our efforts. Yet we believe we can eliminate sustained human-to-human transmission of monkeypox in the region if we commit to doing so and put the needed resources towards that end. That's why this week we have launched 2 comprehensive policy briefs, one outlining the policy objectives and steps needed for the control and eventual elimination of monkeypox, the other specifically on the use of monkeypox vaccines. These briefs provide a clear roadmap for governments and policymakers to mount an effective outbreak response. They also provide a clear message on what we believe our ultimate aim is: to first control and ultimately achieve and sustain elimination of monkeypox infection in the European region. All countries, whether they currently have cases or not, need to implement a set of combined interventions towards this end. We do not say this often enough, but monkeypox can cause agonizing pain to those who have it, including those with sores in their mouth or genital and anal areas. The disease can also lead to life-threatening complications, and it can, in rare cases, cause scarring. The anguish experienced by many patients cannot be underestimated. It can be a truly horrible time. We highlight that support to both the physical and mental health of patients during the entire course of the disease and after it remains of critical importance. Most importantly, with monkeypox, we really must target our response. The current outbreak emerged among men who have sex with men, often through sex with anonymous or multiple partners. That's where the outbreak remains centered, and that's where we must concentrate our prevention and response efforts, with the active collaboration and participation of the community itself, fostering an environment free of stigma and discrimination against this long marginalized population. Here at WHO Europe, we have actively engaged with the LGBTIQ+ activists and organizations, including the organizers of Pride events, ensuring that they receive the best information and advice possible to further disseminate to the community, including at mass gatherings which may serve as a backdrop for sexual activity. Similar community outreach and partnership efforts by some governments for example in Portugal, have also resulted in high awareness of monkeypox, prompting individuals to take precautions and modify their behavior, resulting in better health outcomes and helping curb the outbreak. The third action for today is eradication. This in the context of polio, a disease that crippled many children in our region in the past. As we look forward to celebrating the 20th year of polio-free status in the European region, we are reminded that the momentous progress made towards global eradication is very fragile. In the past years, vaccine-derived polioviruses have been detected in Israel, Tajikistan, Ukraine and the United Kingdom. Given our interconnected world, the poliovirus detected recently in New York in the United States is genetically linked to the viruses detected in Israel and the United Kingdom. Despite overall high immunization coverage, the poliovirus has found its way to susceptible individuals in under-vaccinated communities. This is a wake-up call for us all. It is our shared responsibility to eradicate polio globally. Everyone who is not vaccinated or whose children have missed their scheduled vaccinations should seek vaccination as soon as possible. Polio vaccines are proven to be very effective and very safe. Polio, monkeypox, COVID-19, all of these have demonstrated repeatedly that a disease threat anywhere can quickly become a disease threat everywhere. A lesson we would indeed be foolish to ignore, all the more in the world of today. And with that, thank you for your attention and we look forward to taking your questions.
Thank you very much, Regional Director, for your opening remarks. We'll start the Q&A section of the press briefing now. As I said, if you'd like to raise your hands in the system, we will come to you. And we also have some questions that we've received in advance. I believe we're going to take a question on Ukraine first. Is that from Ed? Ed, if you're online and would like to ask the question, let me know. Otherwise, I'll ask it on your behalf.
Yeah, thanks a lot, Banu. If I could just ask very quickly, is the WHO concerned specifically with COVID, a possible spread of COVID-19 in Ukraine this winter, given that the healthcare system there is already under extreme stress because of the war?
Thank you very much, Ed. We'll go to the Regional Director first and then to Dr. Smallwood.
Thank you very much, Ed. So I myself have been 3 times this year already to Ukraine, including closer to the front line with the border of Belarus and the Russian Federation. And the health system is under tremendous stress. As of today, almost 500 attacks on healthcare are being reported by the WHO surveillance system. But at the same time, I must say that the resilience and selfishness of the Ukrainian healthcare workers is really the spotlight in these dark times. What are the acute needs? The acute needs are still to strengthen the emergency medical services, including blood banking, number 1. Number 2, to prepare for the winter. And for this, together with the Ministry of Health, we're assessing the capacities of the hospitals in terms of oxygen supply, of generators, also to strengthen rehabilitation for the injured people, and continuation of treatment of what we call non-communicable diseases like cancer, hypertension, other cardiovascular diseases, diabetes, particularly for patients in occupied territories. The number 1 priority is for WHO to get access to Mariupol, Donbass and the occupied territories. On COVID-19, just like in the rest of Europe, we are seeing an increase driven by the BA.5 sub-variant. And I was mentioning in my statement, just like in the rest of the region, we definitely anticipate an increase also of COVID-19 in the region. For a bit more specific details, I will pass on to my colleague, Dr. Smallwood.
Thank you, Regional Director. Just to add that, of course, we've been worried about COVID-19 in Ukraine since the very beginning of the invasion. And of course, we saw several significant peaks in COVID-19 in the winters of 2020 and then in 2021. So we would expect another peak of transmission occurring along with other European countries come the autumn and the winter. Managing that will, of course, be a challenge, but I'd like to recognise that despite several challenges in the response to COVID-19, the country and its people are continuing to respond. Having said that, we are seeing a big hit to the ability of the country to report cases, and that's been really a product of the war. So we look very closely at the trends, and as the Regional Director highlighted, we are seeing a resurgence of COVID at the moment with BA5, the Omicron sublineage, spreading in Eastern Europe, and that's likely contributing to increasing numbers of hospitalizations, and we've seen a small increase in deaths in the country as well. But as part of the winterization planning, we'll be working very, very closely with the Ukrainian colleagues and our populations to really put a spotlight on the need to put in preparedness for COVID-19 and for other respiratory viruses as part of that.
Thank you very much, Dr. Smallwood and Dr. Kluge. Let's take a question we've received in advance from AFP, Camille Basvolet. And I'll go to the Regional Director first and then again to Dr. Smallwood. Monkeypox, she asks, monkeypox infections are declining in Europe. Does WHO think the virus has peaked?
Thank you, Camilla. So these are early signs, so we're always a little bit careful to make definite statements, but of course this is going in the right direction, but it's not enough. As I was mentioning in the statement, we need the comprehensive measures, including disease surveillance, the contact tracing. The key issue, actually, which we learned also from the early days of transmission of HIV/AIDS, is that we are not going to eliminate the monkeypox outbreak without involvement of the communities. And that's why very early on, in fact, we're sitting here in the same room with the organizer of the European Pride events and the director of the ECDC. We continue to engage with the LGBTQ+ community, and that we will continue to do. Often we look a little bit at the dark side. Let's look at the positive side, like Portugal, where Portugal, in the absence of a full-fledged vaccination campaign, did manage to curb the increase through behavioral change and engaging with the communities. Empower really trusted messengers to the community. The second one is the targeted use of the available vaccines and treatments. But again, for some more details, I will give to Dr. Smallwood.
I think the Regional Director highlighted most of the important points. Just to add that we are now beginning to see across the region a week-on-week sustained decline, especially if we're looking at the onset of cases. But I would agree that we need to be quite cautious. But more importantly than that, I think we need to continue to really build on the momentum that has been built over the past several months. And the decline in the European region, particularly in countries that have the largest number of cases, has really been driven by this amazing engagement across the community, but with also these public health interventions that have really begun to take shape. And we need to strike while the iron is hot. And that's why we've really issued these two policy briefs with a very clear policy objective, which is elimination in the European region. We need to build on the momentum. We need to really take advantage of the fact that this is still high on the agenda, and we need to act quickly in order to really sustain the early successes that we're seeing.
Thank you very much, both. Let's take a question from a live question now from Donato Mancini at the FT. Donato, please do ask your question.
Hi, good morning. Thanks for the briefing and for taking my question. I have a somewhat technical question. You said that the poliovirus detected in UK, Israel, and US is genetically linked. Is this the first time this has been established as fact? Because I know it had been floated as a possibility, but officials were still very cautious about it. Is this the Is this new, in essence, is what I'm trying to ask you. Thank you.
Great. Thanks very much, Donato. We'll go straight to our vaccines expert, Dr. Datta. The floor is yours.
Thank you, Donato, for asking that question. As while we are having this press conference today, WHO Europe is engaged in a dialogue with the Ministry of Health in the UK, the Israel, and also the US. We yesterday had a global call where WHO Americas and WHO European region, together with headquarters, looked very closely into the virus tree that is evolving, most specifically into the technicalities of the virus that has been detected in the sewage in the UK, in Israel, and also in the US. What we can say to you at this point of time, while the discussion with the Ministry of Health will evolve, and we'll be very much glad to keep you and others posted on it, that the viruses that we have detected in the sewage in UK, Israel, and also in the US, they're genetically linked. But I think what we need to understand a bit better moving forward, what are the linkages around the cases. So epidemiological investigations will lead us to join the two dots. Viruses are genetically linked, but whether there had been any history of travel or any other linkages that we can find between the communities which are affected. I think let me also take this opportunity to link it what our regional director has mentioned. The detection of these viruses mean only one thing, that we have left our population somewhere under-vaccinated or unvaccinated. And I think that should be the call for all of us to look into. Let us vaccinate whom we did not vaccinate. And the virus is a good thermometer to tell us where the health system has left people behind. And while we are working on the genetic linkages for sure, I think we need to draw ourselves to the drawing board on getting people vaccinated, because this vaccine is very effective and very safe, as you have heard our regional director say.
Thank you very much, Dr. Datta. I'll take a question now from Sarah Newey from the Daily Telegraph, who's written in the chat there. She's asking, what does the experience of the Southern Hemisphere with influenza tell us about what may hit the UK and Europe this winter? How big is the risk of a so-called double whammy of COVID and flu? It's been discussed for several years. Is this the year that fears are realised? Dr. Smallwood, if I can go to you for that, please.
Thanks, Sarah. That's a really good question. And of course, we can't speak with any certainty because each region and each country has its own specificities. But we have looked quite closely at the flu season in the Southern Hemisphere, looking at countries such as Australia, where they saw quite an early and a sharp increase in influenza in the season that did contribute to some pressures. Also in Latin America, we saw some pressures on health systems. And of course, what we need to look at is the fact that some of the population groups that are at risk of more severe disease when it comes to influenza are different from those when we talk about COVID-19. So these are all things that we're taking into account, and these are incorporated into some of our modelling and our sort of speculative work looking at the season to come in Europe. We're also looking at joining up the responses as much as possible and integrating them. So looking at integrated respiratory virus surveillance, looking at joined up strategies for vaccination in the autumn, and perhaps my colleague Siddhartha would say more about that. But we don't know what's going to come. But what we do know is that it's likely that the preventive measures that have really kept seasonal flu at bay won't be in place in the same way that they were in 2020 and 2021. So there will likely be an interplay between the different viruses. It may not be a typical flu season. We might see an atypical. It might come early, it might come a shorter period, it might come later on. So we need to be really agile in our response and be ready to respond to any changes in the virus circulation.
Dr. Datta, would you like to come in there on vaccines?
Sure, thank you so much. And I think just building on what Katie mentioned, we all know what are the interventions needed for both COVID-19, influenza, and others. I think it's important that we make use of them. And I think the point that Katie was mentioning, that vaccination will definitely play a big role in the upcoming flu season. We all are aware that influenza leads us, the vulnerable population groups, to the healthcare, overwhelming the healthcare system because they will end up in the hospital. They can also end up in the ICUs. So I think if we can make effective use of the available vaccines that would be coming, but also, as you have heard our regional director mention, we need to make use of the COVID-19 platform for effectively using these influenza vaccines whenever it is feasible and whenever it is available with us. So I think let us be prepared using better or most for the intervention tools that we have on our hand, and vaccination is one of them.
Thank you very much, Dr. Datta. I see Sarah has just a quick follow-up question for each of you, Dr. Smallwood and Dr. Datta. Dr. Smallwood, Sarah's wondering about the modelling, if you can say anything about the modelling that you mentioned on flu and COVID. And on polio, Dr. Datta, how significant is it that the samples from sewage are genetically linked? Was this a surprise? Does it suggest that all cases came from a common source?
Let me just clarify on the modelling that it's mostly focused on the transmission scenarios for SARS-CoV-2, together with different interventions that would be put in place in order to control the pandemic. Those are available in the autumn strategy that we published in July, and they come from different institutions. We looked at 3 separate models and brought them together, and they influenced the way that some of our recommendations were defined, and we can share that with you in due course.
Thank you so much, Sarah, for asking that question. Let me clarify one thing, that when we are telling when we say there are genetically linked viruses, we haven't seen any case of paralysis in the UK. We have seen the virus being detected in sewage. And when we find this environmental surveillance, as we say, when we detect virus in sewage, and the sewage in, say, for example, these cases, this sewage has been detected in London, Greater London area. So the sewage is coming, or the stools are being drained into the sewage from across communities, which are, in the Greater London. So because we haven't seen any case in the community, which means that the characteristic of this population group, which is draining into the sewage, need to be looked into very closely. And that community means the community characteristics of people's movement, the community characteristic of people's health-seeking behavior, which are leading to under-vaccinated or unvaccinated children in that community. While the genetic linkage in the virus is ongoing, as I have mentioned earlier, we now need to look into the wider epidemiological investigation of the community, the individuals, and the children who are affected. And as we speak today, this entirety is going on, and really like to thank the government of the UK and also government of the US for allowing and sharing this information with us. Without that, genetic linkage of virus would not mean much to the global scientific community. And we will keep you and others posted as we hear better from our member states. Thank you.
Thank you so much, both of you. So let's take a question from Natalie Grover from Reuters. Natalie, please unmute yourself and ask your question.
Hi there. Thanks very much for taking my question. I was hoping you could talk a little bit about, the why you think the monkeypox outbreak is slowing. We've heard some scientists talk about this perhaps being more of an indication of a behavioral change than the impact of the vaccines. And I was wondering whether you agree with that. And secondly, how things are in terms of the supply situation. We know that there's been a supply crunch, and of course there are other plans to stretch out doses. But just wondering when those actions are going to be started and how we should think about supply in the near to medium term. Thanks.
Great. So 2 parts to your question there. So I'll again go to Dr. Smallwood and Dr. Datta. Dr. Smallwood, on how monkeypox is it peaking or why it's declining? The floor is yours.
Thanks for that question. And absolutely, it's going to be very difficult to really pinpoint behavioural change as the purpose for the reason for this decline. However, what leads us to think that that's certainly playing a role is up until recently, and still in many countries, the absence of vaccine supply, and the time that it takes to both organize and deploy the vaccine, and then for the vaccine to take effect. So what we're seeing in terms of the epidemiologic picture, we must always remember, based on the incubation period of the disease, is a little bit what was happening in the past. And we have seen a week-on-week 4 or 5 countries that are seeing the largest number of cases. And the reasons for that are probably a variety of reasons. Earlier detection, which leads to patients isolating themselves sooner when they know that they have the disease. Behavioral changes. We do have some pretty good anecdotal evidence that people are, particularly men who have sex with men who are in particular risk groups, are much more informed about the disease, and there's ample evidence on the ground of extensive work going on at the community level with very, very strong engagement from civil society organizations and very, very strong engagement from the at-risk populations themselves, which really leads us to believe that behavior change, at least for the moment, is contributing very significantly to that. But we, as we've said, we need to build on that, and we need to absolutely do more. So there's not going to be one silver bullet here. There's going to be a range of imperfect interventions that need to be layered one on top of the other. And we firmly believe that if we continue to do that, we will be able to sustain this decline.
Thank you very much, Dr. Smallwood. Dr. Datta, on vaccine supplies.
Yeah, thank you so much, Nathalie, for asking that question. And I think it builds upon what both our regional director and Katie has mentioned. Vaccination alone is not the only tool which will help us to interrupt the human-to-human transmission and thereby eliminate monkeypox in the WHO European region. Vaccination is only one of those tools. And when we talk about vaccines and vaccination, we are all aware of the recent scarcity in the global supply. That also has hit the European region. But I think it's important that we first of all, I think we acknowledge the research and development that has happened, not today, but it has been across so many years that we were preparing ourselves for the smallpox and monkeypox vaccine. We also need to acknowledge that because of those research and development efforts, the global community could be provided with an additional tool in the toolkit to control the monkeypox outbreak. What the research and development is also ongoing in terms of using the scarce resources to its better potential to have a bigger impact. One of those strategies which is being outlined is to direct the vaccine to the highest of the risk within the high risk community. So better use the available resources. That's number one. Number two, within the vaccine dosing is another research and innovation that has been done, whether we use a full subcutaneous or an intradermal vaccine, and I think this is another innovation that has been done. What these vaccines and the other intervention tool in monkeypox is teaching us, as a global community, we cannot be static. We need to look around what are the different measures that can give you much better impact to the interventions, and we tailor as we go along. Like Katie has mentioned, it could be imperfect, but I think we have to make use of the available resources more perfectly within this imperfect world. And I think thereby we'll be reaching somewhere much better impact to the vulnerable population group who are disproportionately affected by these diseases. Thank you.
Thank you, Dr. Datta. So we're just going to move a question now on COVID, and I'm going to be going to the regional director and then to Katie. This is also from AFP, and they're asking what can be expected this autumn when it comes to COVID-19, and will you be recommending a second booster shot for every adult? Regional director, would you like to start?
Yes, nice to have you again, Camille. So what I see was happening in the region and globally is that people stabilize their lives without actually stabilizing the pandemic. And I fully acknowledge that politically it's very tough to promote measures to a tired and sometimes resistant population. But yes, we do anticipate a surge in autumn and winter, hence that the winter and autumn strategy on the COVID-19 was launched as early in mid-July, not to wait till the autumn, but to do a number of things to minimize such a surge. And the individual measures I mentioned in my statement, but definitely it's recommended to have a second booster in the risk groups, like the elderly people, the people who are immunocompromised, the healthcare workers, the social workers, who can definitely benefit and should benefit from a second booster, together with targeting the use of antivirals to keep people off the ventilators and avoid that the hospitals and the intensive care units are being overwhelmed. Because I would like to make a pitch here again for our healthcare workers who have not had a break in the last 2 years and a half, particularly those who are also helping Ukraine refugees in neighboring countries of Ukraine and in Ukraine. And that's also a very important element, that the COVID-19 winter and autumn strategy dealt with these persistent system issues of, for example, shortage of healthcare workers and burnout.
Thank you very much, Regional Director. Dr. Smallwood, perhaps you want to address some of the scenarios for the autumn season.
Yes, so as I said before, what we're expecting to see in the autumn and winter periods coming up in the European region is one or more waves of increased SARS-CoV-2 activity in the region, with or without the presence of additional waves of other respiratory viruses such as influenza. But not only influenza, we've seen throughout the past couple of years that other viruses have also taken advantage of the changes in the epidemiology in the region, and we've seen that with RSV, for example, as well. In terms of SARS-CoV-2, we continue to see very rapid evolution of the virus itself. So, and those have coincided very much with the new waves that we've seen in the region, and those have spread from one part of the region to another. So these are the types of scenarios that we will expect to see. In terms of the impact of these waves of activity of the virus, given the much higher population immunity that we have at the regional level, overall, we won't see the level of public health impact that we saw in early 2020 when we had not had the benefit of widespread vaccination. However, as I'm sure Siddhartha would note, there remain significant parts and populations, both within the region and within specific countries, where vaccine uptake has not been sufficient, and that's where we would likely see the higher morbidity and mortality associated with these waves. And so a lot of attention needs to go on really bringing up that level of primary vaccination at the population level. It will really depend on how we respond and how services are put in place, as the regional director said in his opening remarks, to make sure that as much as possible cases are detected early when they happen, and that people who are potentially at risk of developing severe COVID-19 have access as soon as possible, and that's really the important thing, early access to any of the additional new tools that we have, such as oral antivirals. And in that way, with the benefit of the vaccine rollout and the higher immunity in the population and the added benefit of early interventions with antivirals, we can really keep the impact low, keep our hospitals able to manage the caseloads that they're going to have to see. And in addition to that, we will just need to keep on with those individual choices of wearing a mask when we're in closed or confined or space with other people, keeping ventilation high, and these are all proven interventions that we may not see as highly technological, but they're cheap, they're simple, and they have an effect, and that's how we can keep the cases low.
Thank you very much, Dr. Smallwood. I'm going to take the next question here from Pooja Jha at The Lancet, and it's going to go to Dr. Datta. It's about monkeypox. There isn't enough evidence, she says, that intradermal administration of monkeypox vaccine works. So how confident is WHO that the monkeypox intradermal vaccination campaign is going to work in Europe?
Thank you so much, Pooja, for asking that very pertinent question. more so when we have scarcity of the vaccine supply, as we have discussed in the last question. But before I answer your question, I really want to reiterate again that vaccination is an important tool against monkeypox, but it is not the only tool. And we have heard from our regional director that it has to be a comprehensive measure and response by everybody involved. It's a shared responsibility for us to make use of the available interventions and tools that we have. So now coming back to your question, I think let me also outline a couple of elements here. When we talk about intradermal administration of a vaccine, this is not a new intervention. We have used and we are using intradermal administration of vaccine for BCG, the TB vaccine, but also the healthcare professionals also had been using tuberculin test as an intradermal mode of administration. The topic now comes around evidence of the intradermal administration of monkeypox vaccine. Both US FDA and the European Medicine Agencies, when they have authorized the use of this vaccine for smallpox and monkeypox to be used as an intradermal administration for monkeypox, they have looked into the 2015 published data which outlined that if you use an intradermal administration, which is a lower quantity of antigen to be used, they are equally effective or to produce an immune response when you do it with a subcutaneous route. So I think it can be pertinently inferred that the intradermal administration has got quite a great potential to increase the impact of the SCARS vaccine that we have at this point of time. But I think the other point is having a vaccine and deciding on the route of administration also includes whether my healthcare professional is capable to give this vaccine. I think intradermal administration of vaccines will require training, because not all healthcare workers are these days the BCG vaccine, which is given intradermal, not used in several countries. So we also need to focus on capacity building of the healthcare professionals who can provide these technical, operational, pragmatic issues that member states need to consider. And one of them is linked to the training of the healthcare professionals. The third, obviously the most important, another important element would be availability of appropriate syringes in the countries to provide these vaccine through an intradermal injection. So I think it's a comprehensive, again, using all these different elements which our policy brief has already outlined. Thank you.
Thank you very much. And we're almost getting to the end, but Regional Director, I'd like to come to you towards the end here. And perhaps I could ask you to reflect on your own experiences in the past with HIV and stigmatization of the affected populations, and now in the context of monkeypox. Have things really changed? How can we push governments and health agencies to do more to reduce stigma?
I would say it's the single biggest threat that we see, whether it's elimination of monkeypox or several other diseases, particularly if we're dealing with key populations such as people injecting drugs, men having sex with men, sex workers, transgender, but also prisoners and migrants and their sexual partners. So it's a whole of society approach. And of course I'm concerned if I see in some of the countries, whether it's west or east in the region, that government policies are being implemented which restrict policies which are conducive for target populations to step forward. Actually, I was discussing this the first week of August during my official mission with Dr. Anthony Fauci, who, as you know, in fact, is a great specialist, particularly in the field of HIV/AIDS prevention and control, when we were reflecting how lessons learned from the early days of HIV transmission apply to the monkeypox, and community engagement and avoiding stigma and discrimination so that people don't go underground is overall the biggest threat we have to attack in line with the human rights instruments that are adopted by all member states. And finally, a word of appeal to all of us commonly to continue to support the healthcare workers, because several of our hospitals, health systems will be strained at some point in time again during the autumn and the winter, and to continue to support our healthcare workers and their families is crucial, because there is no health without health workers. I thank you very much and I wish you a strong health.
Thank you very much, Regional Director. So before closing the press briefing today, let me just quickly remind everyone about WHO Europe's upcoming Regional Committee meeting, which takes place in Tel Aviv between 12th and 14th of September, with a press conference planned on the final day, the 14th. As the Regional Director has mentioned, this is the first in-person meeting of member states in our region since the pandemic began, so there is understandably a lot on the agenda. Journalists are very welcome to attend many of the sessions virtually and, of course, join the press conference. Please reach out to us by emailing eupress@who.int for more information. And on that note, let me close today's press